Welcome again to the 36th PWSA USA Medical Scientific Conference. I have the pleasure of introducing Dr. Deepan Singh. Dr. Singh is a board-certified child, adolescent, and adult psychiatrist who currently serves as vice chair of the ambulatory psychiatry services at Maimonides Medical Center in Brooklyn, New York. Over the past 7 years, Dr. Singh has developed a strong interest and expertise in the management of Prader-Willi syndrome. He has produced numerous peer-reviewed publications and presentations. He's going to talk on the behavioral spectrum in Prader-Willi syndrome and novel treatment modalities. With that, here is Dr. Singh.
Thank you, Dr. Locher. It's such a pleasure to be part of the conference, the convention. Even though I wish that it was live. Now I see only 5 participants on the screen. Is that is that what you're seeing as well? Should I go ahead, or are we waiting?
Well, this is a live stream, so people will be watching us from outside. We're the only one, so we're good to go. You just take off.
All right. Okay. Very good. So let me share my screen, and let's see. All right, so I hope everyone is able to see my screen now. So I guess since it's a live streaming service, I'm not sure if people will be able to send messages via chat. If not, then I hope that there's a Q&A in the background somewhere, and I'll be happy to hopefully we'll have enough time to answer some questions towards the end. I also would request Dr. Locher perhaps or Anne, someone could just give me a heads up if we're running out of time. Okay, so I'm very excited to present this, and I am catering. So there are two sessions that I have during the conference, and this one is called Diagnosing the Psychiatric Manifestations of PWS, Navigating the Blind Spots. The hope that I have in this, in presenting this, is to speak to the caregivers, including the providers, and since this is more part of the scientific community, I'm hoping that all the providers out there, the endocrinologists, the primary care pediatricians, the internists who are hopping on to this live stream will get something out of it. As Dr. Locher mentioned, I'm at Maimonides Medical Center. I'm the Vice Chair of Ambulatory Psychiatry Services, and we are really excited to start our research programming for PWS there. So if any of you are interested in furthering research in the Northeast, that's my one plug for our medical center. Now, some quick disclosures. I do have a grant from the Foundation for Prader-Willi Research. I also have done some consultation work for Solino, and I'm on the scientific review board for both PWSA and FBWR. And just to sort of put it out there, I may mention non-FDA indicated uses of FDA-approved drugs, which is common in psychiatry and in pediatrics in general, and that will be discussed in this presentation. I am a child, adolescent, and adult psychiatrist, and I see patients with PWS across the age spectrum. And whenever possible, I'm going to try to give you some nuances or age differences if applicable. So our objectives today is to recognize the spectrum of behavioral health problems noted in Prader-Willi syndrome, to explain compulsivity, impulsivity, and response perseveration as key aspects of behavioral health problems in PWS, and list the commonly used treatment strategies for the management of behavioral health problems in PWS. Now, this last one is probably going to be, very time consuming if I'm very exhaustive. I'm going to try my best to cover the most important aspects. I hope that at the end of it, we'll all appreciate the need for novel treatment modalities for behavioral health in PWS. Now, before we begin, this is a live and recorded session, so if I goof up or if there are goof ups, just I think that's part of the way life is, during COVID and post-COVID. Remember that I do have both ears, even if one goes missing once in a while, and that's because of the virtual background. I was hoping to have an active chat here so that everyone's engaged. Feel free to, those who are on the call, or if there are questions that are raised, feel free to interrupt and raise those questions through chat or by, when the time comes, by unmuting yourself. We'll hopefully have some time for Q&A. It is impossible to cover all aspects of the behavioral health problems seen in PWS, so we'll try our best, but feel free to contact me afterwards and we can discuss more. So I'm going to start with this vignette, so this is a classic vignette that goes over a 12-year-old male who presents to the pediatric clinic. He's 4 feet 2 inches tall with a weight of 151 pounds. On exam, he has small feet and hands. Parents report that he was born hypertonic. Over the past 3 years, he's described as having insatiable hunger to the point that he has been found to eat out of the garbage when others aren't looking and is continually preoccupied with food. His parents describe that he has been getting more aggressive lately, especially when asked to stop eating. What is the most likely finding on genetic testing? Now, you might be wondering, we are in a Prader-Willi Syndrome Association conference. Obviously, we know the answer. But here's why I put it here. This is a classic vignette which is put in, say, the USMLE or COMLEX exams, which are the accrediting examinations for physicians in the United States. And this weight, the aspect of small fat and feet and hands, hypotonia, insatiable hunger, aggression, and the genetic abnormality. That sums up all that people learn about PWS during medical school. And that's what they're going into their practice with. So it is no surprise then that when you are going to your doctor and you see they're not familiar with the fact that growth hormone is used as a treatment. They're not familiar with the fact that food security is a thing and that patients with PWS are walking into the office not looking like a typical patient with PWS that they're used to expecting based on how they're taught. I think it's important to note that everyone that is on this call who is more familiar with PWS sort of makes an effort to educate other providers, other primary care caregivers, and it also sort of behooves all of the medical providers, including me. Until the time that I saw my first patient with PWS over 7 years ago was my first patient with PWS. I had no idea that it can present in so many different ways. So, and I learned a lot from the patients that I initially saw, and I still see. And the patients that I see are the ones who are teaching me the most. So today's talk will be beyond the loss of function of chromosome 15q, and because that's not the end of it. There's a lot more to PWS. And we all should recognize that there are not enough psychiatric services available for anybody, let alone psychiatrists or mental health providers who are familiar with Prader-Willi syndrome. So there's a real need to spread this education and accept that there might be, depending on your location, there might be no choice, and non-mental health providers will need to educate themselves by reading books, coming to conferences, reaching out to experts in the field about how to treat their patients with PWS who are coming to them, even if they're not psychiatrists or mental health providers. And it's also important to note that some basic principles of management of psychiatric illnesses can help in the management of patients with PWS as well. So coming to the sort of steps, ways of helping patients with PWS with behavioral health issues, it's important to note that every patient is different, and we must invest time in drawing a timeline, really going over the facts. So basically, for those patients who might be on the call, and those who might come in the future to see me, the first question I ask is, my opening statement is forget that I'm an expert in PWS, forget that I know anything about PWS or your child. Let's start from the beginning, right from the time, really going back into the pregnancy, even before the child was born. And even if I'm seeing an adult who's 36, 40 years old, I will start right from the beginning. And that's why engaging the caregiver to draw that very detailed timeline, all the episodes. And why do we do that? We want to distinguish the baseline from new changes, right? Most psychiatric issues, be it a mood disorder or psychotic illness, these are most psychiatric issues as we understand them in the DSM, like in the general public. They're episodic in nature, and they can occur in patients with PWS, and we'll talk about a few of them. But then there are also some issues which are at baseline. So how do we differentiate, say, the irritability or inattention that we are seeing all the time in a child or adult with PWS from an acute change in the behavior? So we need to ask them, okay, this is what you described. Is this different from their usual self, which is called their baseline? So just to sort of go over a quick categorization, this is not sort of like scientifically based. This is the best I could do to just help explain people what we see in PWS. So we'll talk about some behavioral features that would include, say, hyperphagia. Everyone is familiar with. I'm not going to spend too much time talking about hyperphagia because some excellent talks have already been given yesterday, and there are more to come. There's more to come when it comes to talking about hyperphagia. I will talk about aggression, and there is a common theme between and perhaps hyperphagia and aggression, in the sense that that is why a lot of the more recent clinical trials that are being done on PWS, they're focusing not just on hyperphagia but also on aggression and impulsivity. And so one should ask why. Why? There seems to be a common theme, a common pathway, which could be impulsivity. There's poor impulse control that may be one of the factors responsible not just for aggression and other psychiatric issues, but also for the hyperphagia. It's important to note that intellectual disability is common, as most people will realize on the call. But in most patients, in many patients it's mild. And what's also important to note, especially in patients with UPD, but also in some patients with deletion, they have their intellectual issues and learning problems are deceptive, in the sense that they may have a highly developed verbal ability. So they might be able to express themselves very well verbally, but then their executive function, for example, like solving math problems or doing multi-step tasks, will be impaired. So it can be deceptive. So so they might speak like a 15-year-old, but cognitively, emotionally, socially, their development might be behind. So one must make an effort. The caregivers, the psychiatrists, the pediatricians, all the providers, they need to make an effort to differentiate what their chronological age is, the real age, which is 15, versus where they stand in their development, both social, emotional, and cognitive. Autism is common in patients with Prader-Willi syndrome, as has been discussed in other talks during the conference as well, and it is increasingly recognized as a comorbidity that should be acknowledged and treated. The sooner we accept that a child has more than PWS, the more likely it is that they'll get services such as applied behavioral analysis, ABA treatment, which is very effective for when used early in the management of autism spectrum symptoms in patients with PWS. Obsessive compulsive symptoms. Now, psychiatrists and other mental health providers in the field of PWS will agree that patients don't really neatly fit into the obsessive compulsive symptoms. We'll talk a bit more about that in a little bit. They don't really have OCD per se. They may have it, but it would be rare. But they do obsess over things, and they might behave compulsively. And we'll talk about some of the mechanisms possibly behind which might explain it. ADHD, very common in any patient with a neurodevelopmental issue. So, for example, if in the general public ADHD is at a range of about 5 to 6% of the population, the prevalence would be upwards of 16%, closer to 20%. Diagnosable in patients with PWS. In my experience, and this is anecdotal, it's even higher. And their mood disorders, people can have depression. Now, I won't go into a lot of detail about depression per se in today's talk, because depression by itself is not very common in PWS, although I do see it. And it is, when it does happen, it is often missed because the patients will present with irritability and social withdrawal. But then people, with the providers must remember that when there's this recent or sudden change in their behavior where they're not as talkative, not as forthcoming, it's important to speak with them separately without the caregivers and explore more about their depressive symptoms. And I have had a couple of patients who've had active suicidal thoughts, although they haven't. I haven't had a patient who's had a serious suicide attempt. So psychotic episodes, as you know, and it's alarming. I know whenever I talk about psychosis in PWS, the caregivers, the parents in particular, get very worried. They get scared even, and they don't want to hear it. But the reality is that there is a high prevalence of psychosis in patients with PWS. About 24%, if I remember correctly, will have a psychotic episode during their lifetime if they have deletion subtype, and it's much higher, closer to 60% of patients with UPD who will develop a psychotic episode at least once during their lifetime. Now, it's important we should discuss a bit about what's called cycloid psychosis or affective psychosis, which is this amalgamation, this combination of mood symptoms combined with psychosis that we see in PWS. How about anxiety? Now, you notice that I didn't mention anxiety on this chart at all, but anxiety is by far the most common reason that people come to me. So when they're calling me for an appointment, they're saying, my child is really anxious, we need to do something about it. But it's not anxiety per se. Anxiety, if I think a better term to use would be anxiousness, symptoms of anxiety, worrying excessively about something or the other. But let's look into whether or not they actually meet criteria for an anxiety disorder. So let's review some of the anxiety disorders which are common in the general population and are described in the Diagnostic and Statistical Manual, which is the DSM-5, utilized by psychiatrists in the United States. So first is generalized anxiety disorder. This is a free-floating type of anxiety where people are near constantly anxious about everything, anything and everything, right? So they're anxious about whether or not they lock the door, what's going to happen in the exam, what if this, that, or the other thing happens, and they're constantly preoccupied and anxious about multiple day-to-day normal activities. And it can also have physical symptoms, headaches, stomach aches, difficulty falling asleep, backaches. So for all you moms and dads and caregivers out there, many of you can probably recognize that in yourself because it's very common, right? Not very sort of like people diagnose GAD very easily in PWS, but then if you think about it, they're not worrying about the kind of things that you and I are worrying about. The day-to-day issues are not what always bother them. So the most common anxiety disorder is actually specific phobia. So that would be things like a fear of heights, which is acrophobia, or a fear of blood, which is hemophobia, or fear of spiders, arachnophobia. Very specific, circumscribed, and people don't have any anxiety outside of that. I do not see that often in PWS, but it is very common in the general population. Separation anxiety is something that stands out, especially during this time of COVID, and it has really sort of surfaced a lot more in my patients. Separation anxiety is when the patient and the patient is preoccupied and anxious about losing either some harm or death happening to them or to a close loved one, an attachment figure, when they are separated from that attachment figure. As an example, a lot of patients, during COVID became very, very attached to their caregivers, right? They were at home, their schools were remote or not happening at all. Their respite workers were not showing up in adults. The group homes were sort of like isolating the patients, or the day programs had all closed. So there was a lot more interaction and sort of enmeshment, for lack of a better word, between the child or the adult and their primary caregiver. That has led to a maladaptive attachment of sorts, almost like a regression, like a child's attachment to a mom before they start leaving, before they've left home. So that sort of separation anxiety has become problematic and is showing up now that people are starting to go back to life and go back to school, and they've become more clingy, tearful. They've started becoming more agitated, more difficulty leaving home. So separation anxiety can present in many different ways, but has to do with that attachment with that caregiver and a fear of separating from them. And it's not just in children, it can happen in adults as well. Social anxiety, not common in PWS. This is a fear of embarrassment, of saying something wrong or bad in public, and a fear of being around people. So that's not very common in PWS. So we are agreeing that the core anxiety that we see in PWS appears to be different. So now let's talk about obsessive compulsive and related disorders and see if that fits well with PWS. Now we have OCD. I mentioned earlier that OCD, although obsessive and compulsive symptoms, repetitive questioning, repetitive reassurance seeking, compulsively sort of compulsively wanting sameness or preoccupation with schedules, that sort of stuff, are obsessive and compulsive in nature. But it's not, the classic OCD in which the person with OCD has these unacceptable, but difficult to avoid thoughts, or they do things like wash their hands 100 times, or they count every time they take a step. But those kind of compulsions are ego dystonic, which means that they don't like having them. They know that that's not normal. They know that it's not, and they would want to stop, but they can't stop themselves. So that's the more classic form of OCD that I've seen in a couple of patients with PWS, but that I won't classify the obsessive and compulsive symptoms seen in PWS as OCD. Body dysmorphic disorder, not common in PWS. For the interest of time, I'll move on from things which are not super important or relevant. Hoarding disorder, very common, but hoarding disorder cannot be diagnosed in patients with PWS according to the DSM. Basically, it's so common in PWS to hoard objects or things, and I've had patients who hoard keys, who hoard, DVDs, stationery, by far the most common thing that I see people hoarding. And hoarding disorder cannot be diagnosed according to DSM because it's such a core feature of PWS that it's included as part of PWS itself. Excoriation disorder, which is skin picking, rectal picking, they're common, very problematic, and we'll talk about some ways to help with that. I think the talks yesterday spoke extensively about the behavioral means of reducing picking, and today I'll focus more on the psychopharm medication management aspects of that. So again, PWS doesn't fit neatly into OCD spectrum symptoms. So it's hard to categorize the anxiety and the symptoms that we see, the behavioral symptoms that we see in PWS within the constraints of the DSM-5, which is meant for the general public, right? So we usually, and as I demonstrated in that first slide where I showed a case vignette, and that's all most physicians are expected to know about PWS, which is like they see like this one big picture and they say, okay, it's PWS and that's the end of that. And they may have the bias of attributing anything that happens. If someone is feeling faint, someone has clear symptoms of autism, someone has, depressed mood, all of that is sort of blamed on the diagnosis of PWS. However, in rare diseases and PWS, you have to actually look at the trees within the forest. So rather than calling it anxiety, you need to dig deeper and say, okay, what is the symptom of anxiety, the expression of anxiety coming from, what's lying underneath? So what is the diagnosis? Now, if one was to keep within the constraints of DSM-5, we'll find that we're giving a weird mouthful, large diagnosis, something like obsessive compulsive and related disorder due to PWS with OCD-like symptoms, hoarding symptoms, and skin picking symptoms. So as you can see, it's not very helpful to keep thinking about things nosologically, just categorizing it. Rather than that, we need to think about, what is it that we can do about it? What can we help with? Most recently I've been working on, this is something that I'm preparing a manuscript on right now, is describing the kind of behaviors seen in PWS as a condition, like a phenomenon called response perseveration, right? Which is the inappropriate repetition of a particular response despite the absence or cessation of reward. As an example, right, in a person, think about a child without PWS, right? And they really want to go to visit their best friend, right? And this is like a 6-year-old child. And they go and they tug on their parents' sleeves and say, I want to go to see Johnny. I want to go to see Johnny. And then the third time, the parent says, no, we can't go. We have to go see Dr. Singh. We can't go see Johnny today. And the patient might get a little upset, but they see that the parent is getting upset and angry, and that is a signal for them to stop. And they're not going to perseverate over it anymore because they know that they're going to go and get into trouble, or their parents might get even more upset, or they might feel sad themselves, right? So they're able to stop themselves. However, in patients with PWS, despite the negative response, despite the look of sadness on the face of the parent, or anger on the face of the parent, or despite being told that you'll get into trouble, you're going to lose your iPad, you're going to lose your privileges for the day, whatever, they can't stop, right? That is response perseveration. And why is that important? In PWS, response perseveration is clearly, now that we know that it may have a link to the compulsivity, the repetitive reassurance seeking sort of behavior, the repetitive questioning type behaviors that you see in PWS. Now, is response perseveration a feature of anxiety, or is it closer to impulsivity? What is impulsivity? So impulsivity is the tendency to engage in rash, ill-considered action in response to intense negative emotions, right? So I teach medical students, for example, right? And a medical student gets really upset with me giving them a fail grade, for example, right? And the medical student, gets really angry during a lecture and throws, in that anger, throws a chair at me. A reactive type of aggression, a hot aggression. That is impulsivity. They won't do that because they'll get into trouble, and they don't want to get into trouble, and they have what's called the dorsolateral prefrontal cortex, which tells them, listen, I know you hate Dr. Singh, but it's probably not a good idea to throw a chair at them. A child with PWS, however, right, if I tell them, okay, you have to shut your devices off and you have to be in bed by 9 p.m., they might take a swing at me. In the moment, they're being reactive. They're not, it's that hot reactive aggression. It's non-malicious. It is not a planned, cold, Bernie Madoff type, psychopathological sort of, psychopathic type aggression. It's not proactive, it's reactive aggression. And it is associated, impulsivity is associated with low volumes of the prefrontal cortex. So this is the dorsolateral prefrontal cortex, which is responsible for the opposite of response perseveration. It is responsible for response monitoring, what you and I and everyone else who has normal functioning of the dorsolateral prefrontal cortex is able to do. We have the ability and the capacity to be flexible and to respond to the environment, and it helps with our daily functioning, right? So, I won't jinx myself, but if something happened to my electronics right now, I will adapt. I'll bring you up on the phone, or I will finish the talk somehow, somewhere. And I'll try my best not to get upset or, fall apart and give up my profession. You know what I mean? That is response monitoring versus response perseveration, where, why did this happen to me? And I ruin the next 10 days for everybody around me because I can't stop thinking about one negative thing that happened, or one anxiety-provoking thing that might be coming up in the future. So when there's dysfunction with this response monitoring system of the brain, then that leads to inflexibility. So compulsivity, inflexibility, and perseveration. So you see, we're trying to paint a picture here, right? So acute dorsolateral prefrontal cortex ischemia, for example, in patients with stroke, has also been shown to cause perseveration. And we know that in addition to the hypothalamic and pituitary dysfunction in patients with PWS, there's also dysfunction in the prefrontal cortex. So the bottom line is that response perseveration seems to be that missing link that leads to impulsivity and leads to the kind of behavioral problems that we commonly associate with PWS, and it may present itself as anxiousness, aggressiveness, or something else like inflexibility or perseveration. So just to give you a sample, I know we are at 11:50. I would like to stop in the next 10 minutes or so that there's time for questioning. So very quickly, just a snapshot, like we were talking about drawing a timeline, right, with a patient with PWS. And suppose a patient presents to you around 6 years of age, and usually that's the time when ADHD would start showing up. So the child is born with ADHD, always had attention deficit and hyperactivity, may not have hyperactivity, by the way, right? So we don't use the term ADD anymore in scientific communities. We say ADHD, inattentive type, which seems to be more common in PWS. That may have to do with low muscle tone, by the way. That may have to do with hypersomnolence, excessive daytime sleepiness. But then there is inattention, which comes in the way of their performance. They very often, when the kids are young, the doctors would delay starting treatment. Sometimes they would walk into the door of a psychiatrist when the child has been very aggressive with peers or trashed the classroom or something like that. Stimulants were started in this particular example of a patient, which led to severe anxiety in this patient. So this is an example of where low-dose stimulants might be helpful, but then we increase the dosage, and all of a sudden, especially if the child is young, they might display aggression or dysphoria, which is sadness, tearfulness, and whininess without reason after starting stimulants at a young age can be a symptom. Sometimes if you wait it out, that side effect would go away. So these parents decided to stop the stimulants after trying a variety of them. Later on, when the child is starting to grow bigger, they're larger, they start throwing tantrums, which are more aggressive and hard to control. They were, in this particular case, the child was taken to the ER, and they were given lorazepam, which is a sedating benzodiazepine type of medicine. And when they were given that medicine, it's commonly used for sedation in the emergency room in kids. That led to that may lead to paradoxical agitation or severe lethargy, along with respiratory depression, because our patients with PWS already have low respiratory drives. They have central apnea, or they may have obstructive sleep apnea. So it's important to avoid benzodiazepines. Now, at a later age, one of the most common, so if the child, for those of you listening, right, primary care providers feel a lot more comfortable with SSRI type medications, which are citalopram, escitalopram, fluoxetine. And because that's what they're used to prescribing for similar symptoms in patients without PWS. So you can't blame them. That's their education, that's their training. And it can be helpful in low dosages. This patient also had hoarding behavior. So as you can see, it kind of held them for a couple of years. For the worsening anxiety, citalopram was increased, and again, paradoxically, at higher dosages, symptoms can get worse. Mood stabilizers can have additional side effects. Now, what I want to focus on for a second is the fact that, and we'll talk about NAC in a little bit, is that in this patient, if valproic acid was not given, or without valproic acid at higher doses of citalopram, the patient could develop cycloid psychosis, which is what I was talking about, this mixture of psychotic symptoms and affective symptoms, which are mood symptoms, right? And that's very typical in PWS, right? So we presented this paper, and cycloid psychosis is published outside of the US as well. This was a few years ago at this point, but at that point I had 12 patients who had psychosis, clear psychosis, and 11 of them met criteria for cycloid psychosis, right? And cycloid psychosis is interesting because it can present with catalepsy, which is, or catatonic symptoms. They might paradoxically, so all of a sudden, they stop craving food, or they actually lose a lot of weight because they stop eating, they stop sleeping, they appear confused. Sometimes they may not recognize a caregiver. Sometimes they would say things which are bizarre or what we call delusional, which is not based in reality, right? So they would say something like, oh, I had a patient who went to an ophthalmologist and then got psychotic unrelatedly like a couple of years later, and then was convinced that ophthalmologist had planted something inside his eye and was preoccupied with that delusion. And they respond, the good thing about psychosis in PWS is that it comes very suddenly, so you know that this is completely out of the ordinary for the patient. So if that happens, you should bring that to the attention to a psychiatrist. Very often they will need hospitalization if treatment is delayed. I've been able to keep patients out of the hospital under these situations also by aggressive treatment and you have to give antipsychotics at this point. And in my experience, although that's not been studied, without antipsychotics, if a patient has had a psychotic symptom sometime in their lifetime, without antipsychotics, the likelihood of them having another episode is quite high. So it's important to consider giving them antipsychotics to keep them stable. All right, so I'm going to fly through some medication treatment options. Now, my apologies to all the psychologists, the social workers, and all the other wonderful therapists who are in the audience. I'm deferring to all of you to teach the attendees about that. I simply didn't have enough time to cover the non-medication aspects of this treatment. So I have about 20 minutes remaining, so I'm going to try to run through some of these, and hopefully we'll have time for questions also. We discussed benzodiazepines, like in that patient's example, Ativan, or I'm going to use brand names at times just so that you can familiarize yourself, but I'm not endorsing any of the brands. Lorazepam or clonazepam or alprazolam. Alprazolam is particularly problematic because it's very short acting, so people can get habituated to it. So not that I wouldn't call it like people become sort of addicted, but their body becomes dependent on alprazolam quite quickly because it's very short acting, so people can feel it kind of leaving their body and makes them seek more of it. So just keep that in mind. Clonazepam is relatively safer. I have used that in patients who have a lot of panic type symptoms along with PWS. But they can all be problematic because they can, as we discussed, they can reduce the respiratory drive or the will to breathe, the ability to breathe in patients with PWS. We discussed the risk of SRI. So patients, like we discussed, medicines like sertraline, which is called Zoloft, Celexa, which is citalopram, and Prozac, which is fluoxetine, commonly sort of prescribed by primary care providers, and they can lead to manic change. So if your child or if your loved one with PWS has ever had what we were describing previously as a psychotic episode, they should not be on these medications. You should discuss that with your care provider. Atypical antipsychotics are very commonly prescribed in PWS, and they are very effective for agitation and aggression. However, they come with a lot of side effects, right? So long-term treatment, even short-term treatment with antipsychotics, especially atypical antipsychotics such as risperidone and Abilify, which is aripiprazole, can lead to significant weight gain. Probably the worst for weight gain would be olanzapine, which is Zyprexa, and clozapine, which is Clozaril, which is clozapine. However, if you need them, you need them, right? If your child has been stable on it for a long time, I would really consider talking to your doctor about maybe helping with weight loss measures rather than changing the medication suddenly. Haloperidol, chlorpromazine are older or typical antipsychotics, which can cause other kinds of side effects, such as movement side effects, something called tardive dyskinesia, where it's an abnormal puckering type or abnormal dyskinetic movements of the face can start showing up after long-term treatment with those types of antipsychotics. Mood stabilizing medications also very commonly utilized, and sometimes lithium, for example, can be really helpful, but you need to look out for thyroid functioning. It can cause thyroid problems to worsen, especially in patients with PWS who already have thyroid problems. And anticonvulsants such as valproic acid, lamotrigine, topiramate, gabapentin, all of these anticonvulsant type medications come with their own side effects. So I'll go over a few which are commonly prescribed. Valproic acid, which is valproate, is very good for mood symptoms and aggression, but can cause weight gain. Carbamazepine, which is Tegretol, can cause a lot of drug interactions. If your loved one is on carbamazepine, you need to review, your doctor needs to review the other medicines that they're also taking, because even hormone supplements like testosterone, which a lot of our patients are on, or estradiol, they can stop working as well if they're also on Tegretol or carbamazepine. I've noticed that a lot of community providers are prescribing gabapentin to my patients with PWS, and that upsets me a little bit. So gabapentin is a very good medicine for anxiety, but it causes weight gain. People forget that gabapentin can cause a lot of weight gain. So you need to be careful with gabapentin. Topiramate is a good choice for skin picking. I've used that quite a few times. It can, if your child is really high functioning cognitively and is academically very advanced, I would avoid the topiramate because it can blunt their cognitive abilities. Buspar, has been, some people prescribe it for skin picking. I haven't had a lot of success with it. Mirtazapine is something to avoid in PWS because it causes weight gain. Although it helps with anxiety, I would stay away from it. Bupropion, excellent choice for patients who have depression and sleepiness, but should be avoided in anyone who has clear autism, because patients with autism may also have an underlying seizure disorder, and anyone with a seizure disorder who's ever had a seizure should not be given bupropion. N-acetylcysteine is my preferred medicine, along with another one that I'll talk about in a second. One of my preferred medicines for skin picking. And people underdose NAC. So when providers say that, oh, I tried NAC, or the caregivers say I tried NAC, did not work, it's usually that they've underdosed it. And the upper limit is really high. Like I've had patients who've been on 1,800 milligrams 3 times a day if needed. You have to be careful at an older age with NAC, because it's a very strong antioxidant, and it can, you shouldn't give it to anyone who is at high risk for cancers. Okay, so there's some early evidence which I won't go into a lot of detail in, because there are other talks dedicated to these, and these are still being studied. I'm going to talk about guanfacine. This is something that I myself have worked a lot on. This is something which is FDA approved it's an alpha-2 adrenoceptor agonist, which helps directly by increasing the function of the part of the brain that we discussed, the dorsolateral prefrontal cortex, increases the activity there. And by doing that, it reduces symptoms of impulsivity. So it's already FDA approved for the treatment of ADHD. It has also been studied in patients with autism without PWS, and reduces ADHD and impulsivity in them. The most common side effect is tiredness, but it tends to go away after a few days, and does not cause respiratory depression the way some of the sedating medicines we discussed earlier do. So I did an early study, a few years ago with individuals with PWS, and we saw excellent results. This is open label, right? This was not a pharmaceutically funded med trial. Prescribed it in 27 individuals, and 81.8% of them showed an improvement in skin picking, 82.3% in aggression, and close to 94% with ADHD symptoms. So that caused me to sort of pursue that, we need to pursue this as a safer option. Does not cause metabolic syndrome, does not cause weight gain, is very well tolerated. And that led to, I'm grateful to FPWR for funding a study that we are currently recruiting on. So this is my only pitch for the day. If you are interested in the guanfacine extended release clinical trial that we are conducting right now, it's not pharmaceutical funded, and this is a medicine which is already available in the market and has been studied. It's just that it's not been, people in the field are not very comfortable prescribing it yet in the absence of a randomized clinical trial, and that needs to change. And we're hoping that people will come in to New York, visit me, and most of the visits are televisits. So even if you're from out, most of our trial participants are from out of state. So I'm happy to answer more questions about that as well. I do have a small private practice, and the information is right here. The phone numbers on top is for the clinical trial, and the numbers below and the email addresses are given right here. So Dr. Loker and others who are hosting the session, I'm ready to stop and take any questions if there are any.
Thank you so much. I am going to try to field questions. Jim, you can come back on. We've gotten some questions about medication, and I know you discussed the use of medication treatments for different things like mood stabilization. But we have a question about medication treatments for PWS, anxiety, and mood stabilization, which includes the inflexibility, anxious about everything.
Got it. I think the purpose of this talk, and hopefully people got that from this, is that so we have to separate do the opposite of how when we say we want to see the forest for the trees, we have to see the trees from the forest in the case of PWS. So you asked, so in the question, there's no one answer to it, right? So if the child is coming in, if a child is coming in predominantly with impulse control issues, right, and irritability, aggression, and they're doing things without thinking, right, and they're acting out without thinking, and they're not malicious, they're not bad kids, they're just, they're acting without thinking, but they don't have any psychotic symptoms or other mood symptoms, then I would go with guanfacine extended release. On the other hand, if they have psychotic symptoms, or their anxiety has an underlying psychotic phenomenon, in the sense that they're anxious about something which is bizarre or not based in reality, in that case, I might go with something stronger like an antipsychotic. I would, I hesitate. I do not prescribe SSRIs or like the way it is being prescribed in the community right now. I hesitate a lot. I don't prescribe medicines like sertraline, which is Zoloft, or Prozac, fluoxetine, without thinking about it 100 times and really discussing the pros and cons with the parents, because it can backfire. Stimulants, on the other hand, if there's excessive daytime sleepiness and ADHD, stimulants, interestingly, can also cause mood switching and psychosis at high dosages, but at low dosages seem to help without those side effects. Other questions?
And could you address Lexapro?
Okay, so Lexapro is escitalopram, which I would put in the same category as the fluoxetine and citalopram, the others that I was talking about. I hesitate to prescribe it. There are reasons, and some patients will benefit from it, especially the patients with deletion. They're less likely to develop manic switch or psychotic symptoms, so they might be prescribed that relatively safer, especially if they're younger. But in adolescents with UPD, I would stay away from escitalopram or any medicine like that.
Okay, do you use and recommend the DM-ID2, the Diagnostic Manual for Individuals with IDD-MH? It is a section on PWS specifically.
So I don't utilize that for when you're talking about like for as a diagnostic tool, like as a template. Was that the question?
I think so.
Okay, so I don't, when patients come to me, they already have the genetic diagnosis of DSM, and the when I'm going into the sort of like the details of it, I haven't found any particular scale to be very helpful. I think Eric Hollander's homegrown scale that he has developed for clinical trials probably covers more of the behavioral problems than the other scales that exist outside, because that's PWS specific. But otherwise, I don't use scales. I use this semi-structured psychiatric interview that I described earlier in order to get to the diagnosis.
Okay, and that goes back to another related question. What do you say to some that argue that ASD is overdiagnosed due to overlap in developmental delay in the social and cognitive responses?
Right. So that's so this is specific. My answer is going to be specific to the United States of America. I know that people are viewing from across the world. In the U.S., the public school system is supposed to. It's their legal obligation to educate the child, right, and provide services to the child depending on the state that the child is in. PWS is extremely rare, right? 1 in 60,000 live births, as compared to autism, which is 1%, 1 in 100 kids will have autism. So obviously there are a lot more services for patients with autism, and autism is way, way more common than PWS. By missing the diagnosis of autism in patients with PWS, we are depriving them of a ton of services, and they're appropriate services. Autism can be DSM, the DSM manual for the diagnosis of mental illnesses allows the diagnosis of autism even in patients with neurodevelopmental disorders such as PWS, as long as the symptoms are causing impairment socially or emotionally to them. So if they are if the symptoms of autism are impairing, don't limit the child to being diagnosed with PWS alone. Please give them the diagnosis of autism, because there are so many more treatments that open up, such as ABA, which you'll hear more about in other talks in the conference.
Okay, fantastic. We had some questions about naltrexone for skin picking.
Yes, excellent. That's a good question. Naltrexone has been studied for skin picking. It's an interesting medicine because it can also, especially in combination with topiramate and other medicines, it can also cause weight loss to some extent. It's been a mixed bag in my experience. You do have to look at liver functioning pretty closely before starting naltrexone. It's other than that liver toxicity that can happen sporadically in a few patients, it's very well tolerated. Even at starting dosages, you can just right away start them on naltrexone. But then if it's the evidence is sparse, I don't use it very frequently, because suppose for skin picking, I find NAC and guanfacine and topiramate, the three of them, to be more effective than naltrexone. But that's my experience. Head-to-head studies have not been conducted.
Fantastic. So we have a good question. If someone comes to you with a genetic factor such as COMT or MTHFR variation, is that something that you that factors into your plan of medications, such as avoiding SSRIs for psychotic breaks?
No. Okay, I'm grateful for that question, because this has become, it's almost like FDA has sent out warnings that a lot of these companies, these are kind of capitalizing on desperate parents and families who are trying to get genetic testing done. So pharmacogenetic testing is not very well developed in psychiatry in general. The only thing that it has really been shown to be helpful for is fast metabolizers of medications or slow metabolizers of medicine. So for example, if a patient with schizophrenia or with PWS is not responding to any medicine at all, and they've been tried at high dosages of every medicine, all the antipsychotics, for example, right? Like 3-4 different antipsychotics, no response at all, then a pharmacogenetic testing makes sense. Otherwise, we really jump the gun without much evidence for the support of these studies. And suppose, let me give you an example. Suppose your child is doing really well on risperidone, and then you go get a pharmacogenetic testing because somebody sort of like made you spend $2,500 to do that, and then it says risperidone is not good for your child. Are you going to stop it? There's no evidence to support that decision. So, and more studies, very recently, another study came out in the journal, I think it was the Journal of Child and Adolescent Psychopharmacology, which showed that pharmacogenetic testing, should be avoided for regular cases unless there's real need and you can demonstrate treatment failure. So that would be my comment on that.
All right, fantastic. Do you have a comment about the role of sleep apnea treatment in addressing behavioral problems?
Oh, wow. So this is huge, so important. See, that's why I love Q&A. So sleep apnea is, first of all, very common. I think sleep studies should be done on a regular basis. I think folks like Jennifer Miller and Maurice Angulo can tell you more about how frequently they should be done, or Dr. Cataletto maybe. But they should be done at regular frequency, especially if there's a significant change in the size or weight of the patient. Sleep apnea, untreated sleep apnea will imitate all of the psychiatric features that I've described. Other than psychosis, it will cause inattention, it will cause daytime sleepiness, it will cause irritability, it will cause aggression, it will cause depression, it may cause anxiety, it may cause school refusal, all of that stuff. So untreated sleep apnea is a big problem, and you need to treat it with CPAP. Preferably, you might have to try different masks. In my experience, although it's not the best thing to do, I have had patients who have failed, who've refused to wear CPAP for over 6 months. Everything has been tried. And then I prescribe them stimulants or something like modafinil, at least to take care of some of the daytime symptoms that come from sleep apnea, untreated sleep apnea. Good question.
Okay, fantastic. What are we doing on time, Jim? Are we getting close to shutting down?
Yes, I think we are. We have 12 more minutes before the next session.
Okay, so yeah, I think we're going to have to give folks a break, but thank you so much.
It's been my pleasure. I hope people found this helpful. Happy to answer any other questions that come up if you need any help. And thank you so much to PWSA for organizing this and for inviting me to present. Thank you. Thank you so much.
Thank you.